There we go. Okay, we are recording. All right, thank you guys all for being here again. This time, so just the monthly journal club, I threw a fastball this month, and we're on the second Monday of the month, but normally the first Monday of the month will resume back in September. So this is the last one for the school year. We'll have summers off, and then we will be back in September. So watch for that. But today we have four experts in the field. So OTs that all work in pediatric practices. So we have Ivan Hardcastle at Primary Therapy Source in Twin Falls. You want to wave?
Yep. I'm the token male. There's always one token male.
You might get Ivan mixed up with somebody else here.
Yeah, fair enough. And we have Lisa Hong from Generations Therapy. And we have Lindsay from Connections in Blackfoot. And we have Carrie Thompson representing the Treasure Valley in Boise at Children's Therapy and Learning Center. So today is basically super informal, but I mean, so me, I've never worked in pediatrics. I never even had a fieldwork rotation in pediatrics. So it's something where I definitely have a lot to learn, but this is really informal of, let's talk about the challenges that come with pediatric. So I had kind of a template of questions that can maybe get us going and going into conversations, but then I think for anybody that, you know, we go where the conversation takes us, or if anyone has a question that they want to interject, this is super informal, and hopefully just we'll go with the flow of conversation to really kind of reach those, what are the best practice techniques for our pediatric population. So I know, just being in academics, one thing that I always hear about, or when I'm doing my fieldwork site visits and whatnot, I always hear fieldwork educators talk about, you know, the challenges with behaviors. So maybe we can talk about that, because I think that's, you know, for me as an adult therapist, that's one of the most intimidating things, is what would I do with a child that is having a meltdown or having struggles with behaviors. Anyone want to take that one?
I'll go first. Yeah. You know, most of my students that I get in, that's also their biggest concern is, how do I manage when this kid has a meltdown? How do I manage when the kid gets angry and throws things, or he tries to run away? And you know, there's two big perspectives that I usually look at. Number one, sometimes this is hard to do beforehand, because maybe they've been absolutely fine up until this point, and so you haven't had this conversation just naturally come up. But make sure that you have the conversation with the parent as to, hey, you know what, is there something that you want us to do in particular when your child is having a behavior, and make sure that the parents are very aware of what's going on and are very involved. Sometimes they have a behavioral plan already in place, and you want to be able to follow through so that there's consistency. And then the other one, as far as from a therapy perspective, my big frame of reference really comes from sensory integration. And so I always try to take a step back and say, okay, where is this coming from? Is this an inability to express themselves? Is this a sensory overload of some sort coming from, is it the room that we're in? Is it the activity? Is it, you know, some other element that I'm not aware of? I'm always fine, not always, a lot of the times, I'm fine with stopping whatever activity that we're trying to do, whatever skill we're trying to build on. If the child is having challenges with it, stepping back and saying, okay, do we need to go and do we need to re-regulate, recenter, refocus, and get some organization back into their system so that we can then re-engage and be successful. And each kid is different, and each situation is different. But you know, I guess an example. This is actually comes from a teenager. I think, you know, a lot of times we think of younger children, and they have tantrums and challenges. But this teenager I've worked with for 12 years, 13 years. And he would, it seems like everything's fine, we're going along, and all of a sudden he'd grab something and just throw it. Walked into our office one day, took off his shoe and threw it over the counter at our scheduler. It was just bizarre stuff. And I started recognizing that some of those antecedents to what was going on were very, very, very subtle. And just spending time to really get to know who you're working with and allowing them to get to know you really makes a big difference. Seeing them as an individual rather than, oh, this is my 9:30. And I think sometimes therapists, we can fall into that trap of we're busy, we're pressured, and okay, I gotta get through my 9:30, and then I gotta get to my 10, and then I gotta get it to my 10:30, and slowing down, seeing them, re-looking at them as a person, because that's where we started, and making sure that doesn't get lost. Carrie, I'm interested in hearing from you because I know some of your organization, and I bet that you have some fantastic input in this area.
Well, I think what you said is great and absolutely exactly right on. I also would use a sensory integration approach. I oftentimes think of what we see as behaviors is secondary to a sensory dysregulation, rather it be either overstimulated or not understimulated. And I always just go back to, again, what caused the behavior to begin with. And I think from when I'm looking at, again, when students are coming in, the first thing I always say is you have to, number one, set up your environment so it's ready to go for that kid. We set them up for success, which is not always going to be what happens at home or in school. But from a therapy standpoint, we try and make sure that when they come in, we're ready with a visual schedule, or we're doing the visual schedule with them, and we're creating the plan for when they get there. And it could be just from the very first thing is take off your shoes as soon as you walk in the door. And then also just the sensory prep. Are we going to put on a compression vest? Are we going to put on a SPO shirt? Are we going to put on SPO garments? Are we going to put on therapeutic listening? Are we going to do a deep pressure touch protocol right away? Really just setting them up with the tools on their body, and then also then going to sensory prep to, get their systems, their sensory systems ready to be able to learn. So we want that optimal level of arousal, because that's how they're going to best be able to learn in our sessions. So do we then go and do, vestibular, and then followed by some probe, and then we're going to do the fine motor and the visual motor activities at the table, but to, again, kind of go through an entire system and a process each time versus just jumping into what might be the most challenging. But like Ivan said too, absolutely, if we're seeing any setbacks at any point of the session, we're going to stop what we're doing right there, kind of look at the big picture of, wow, what caused this little bit of regression in the moment? What do we need to do to reset them and bring them back? That's, usually what I do. And the other thing is like Ivan said, you never know when a child is sometimes going to fall apart, and all of a sudden they're whipping something at you, or they're punching you in the nose, and you had absolutely no warning. It happens throughout our day for sure. But I think that's the other thing too, is when it does happen, just, you really can't have a reaction. Sometimes the more reaction you have, the worse it gets. So yeah. I think just staying super calm and just, that was unexpected, and you just, you back up and you just go from there. So yeah.
I can't remember where I heard this from, but I've internalized it as a I don't know what it's not a mantra, just a mode of thinking, that the belief that every child innately wants to be successful. Mm-hmm. No child in my mind, I don't see children going out there saying, hey, today I want to fail. Hey, today I want to throw this huge tantrum and just upset everybody. They want to be successful, and they innately want to be successful. Sometimes things happen that make that difficult for them. And you could look at, take into factors of family and home environment. What does their home look like? Are they in some sort of a abusive home where parents are angry all the time, or they're we don't know what's going on. And so sometimes you have this added component of the way that they have learned to communicate above and beyond their regulation needs is that in order to get attention and in order to engage in the task, I do these things. And so you take those into account as well. And it's really cool to see some of the kids that do come in, and that they come from rough homes. And as they get to know the therapy environment and the therapist is able to show that genuine interest and love through therapeutic use of self, that they change, and it's really neat to see how they change and they respond. And then you can go back and using those sensory approaches all the time, and but you also take care of that initial way that they've learned to engage in their world and try to meet their own needs on a cognitive and a psychological level.
And kind of taking it a step further from that, getting to know the kids and what they enjoy and using that through their hard challenges. Like I have a really challenging Monday kid and he is obsessed with octopuses. So we use that for the coloring and the cutting and the drawing. And so using that and then maybe even a visual timer so they know how long they have to work on the super challenging activity that you want them to work on too can really help keep kids on task and help manage kind of the behaviors as well.
It's interesting as you're talking about these so Joanne and I in my other life work on like on the geriatric side on dementia, and we always talk about how behavior is communication, and all of these things that you guys are describing also happens in a dementia population because those communication skills are so limited. Sometimes they have a lot of feelings and they don't know how to express them or don't have the ability to express them. And so throughout the lifespan, this can definitely be an issue. So it has a lot I'm glad that you guys are talking about like the antecedents and stuff, because that's totally what we're looking at. Another thought I had too while you guys were talking was about I think sometimes people have a hard time seeing that behavior management as like a skilled intervention, so they're like, well, you were just wrestling the kid, how do you build for that? And so being able to describe that and having it is a skilled intervention, and self-regulation is huge, and so no, we can't work on fine motor skills all the time because we have to have self-regulation first. So I think students definitely have questions about that when they come in, like how do we build this? How do we describe this?
Bouncing off of that, Lisa, I was going to say the same thing about the dementia population. It is so true that everything you were saying, I'm like, gee, that sounds like my dementia lecture. But the other thing that Lisa's just talking about is it is billable, and it's important to document because you are helping identify how to find out what the triggers are and the things that help calm the kid or get the kid to do what it is you need to do, and passing that on to the teacher or to the teacher's aide or the family members for when these things happen at home or outside of your treatment session. So wrestling a kid can be part of what it is you need to, well, not the wrestling part necessarily, but the part that comes out of it and what you learn about the behavior and what worked and what didn't work. It's important communication.
Two things that came to my mind. Number one, Lindsay, back on octopuses. This is totally an aside, but it's fun. So in one of my school districts that I contract with, I hadn't seen these before, but they're these little plush octopus things. And it's the one that they got, it's yellow and it has a smiley face on it, but then you can pop it inside out and it's hot pink and it has a frowny face. And so then it's just this really cool tool for them to just have a quick, hey, is today a good day? Is today a hard day? And they can just pop this octopus, and it's an octopus. And I was just like, oh, good heavens. There's something for your octopus kid. The second thing that I was thinking, and shoot, now I've lost it. I've lost it. It was really good though.
billable services, documenting.
Oh, that's what it is. Thank you. Okay, so we have this is an ongoing thing, but our big push for it was several years ago. We got permission for photographing clients in therapy sessions from parents, and then we took pictures in sessions and we blew them up and we used them as wall hangings throughout our office. And so not only is it kind of fun to see our therapists up there and see some of the kids as we've been working with them, but then it becomes a really good tool to teach the parents. And talking about wrestling with a kid, one of my favorite pictures, and it happens to be me. That's not why it's my favorite, although it's great. It has a kid on the foam stairs, and he's leaning down and he's turned to the camera and he just has the biggest grin on his face. And I'm right next to him and I'm in the middle of pounding on his back, because that's one thing that we found that he just craved that compression, and it just totally relaxed him. And you can see it in his body language, just the way that he's just like melting into the stairs. And so I can use that and say, hey, you know what, sometimes it looks like we are just playing. It looks like we're wrestling. Look at this picture. This is the situation that's going on, and this is how we're going to apply it to your child. So.
I think.
The end.
Oh, yeah. No, so I mean, the next question I had, which kind of builds off of this nicely, is just, I know how difficult follow through can be at home. And I was thinking particularly to behaviors, but in the pediatric population, behaviors as well as everything else, like are there any strategies or tips for improved compliance at home? Or, how do you handle, a parent that has multiple kids and, and just, it's not happening at home? Like any strategies or challenges or success stories that you guys can share?
Before a success story, I just want to say one thing that I've learned over the years is that I've learned that we just can't assume anything. We know such small amounts of what's going on in the child's life, and I don't have a child with a disability. I don't know what it's like to live with a child with disability. So to keep my expectations of, I want them to do this home program, but understanding that, man, they're just getting through the day sometimes. I have no idea what they're dealing with, and so to kind of cut them some slack that way, but really encourage. It's been a huge eye opener, because people just we're just all trying to survive sometimes. So.
And tagging off of that, if you ask the parents what their priorities are, you're going to get a whole lot more compliance. Like if your goals are based on the parents and the child's priorities at home, you're going to get a whole lot further in the compliance. Oftentimes, especially with some of my little bit older kids, I put the compliance part on them. And they have a chart of success. And if they're able to get whatever we decide is the number of times that we want them to do it at home done, and they bring it back, then they've earned something for a therapy session the next time to help with that. So I don't always put the compliance on the parents. Sometimes it's just as easy and better even to put it on the kiddos themselves.
I use that a lot. I like that. And it works a lot more. As soon as I can see a child develop ownership of the therapy, that's when I see a lot of progress. When parents see ownership of it and are bought into the therapy, you see good ownership, you see good progression. But when the child does, man, things really take off. I've used sticker charts. I've used, hey, you know what, you need to come back and you need to report that you did, whatever 3 times for me. And I'll write a note that they can carry. And hey, where can you put this so that you remember? And because I think of putting it on the fridge. Is that going to work? Oh, no, I don't really look at the fridge. I'm going to put it on my bathroom mirror. I'm going to put it on my wall. It's like, hey, that sounds like a great idea. And suddenly it's their idea. And then they put it somewhere where they remember, and you still don't have perfect success, but you have greater success.
Yeah, I agree as well. With the older kids, we definitely try and get their buy-in. and also find out what do they want to improve with. Again, it's not just what the parents want them to improve with, because if you have a teenager and it's not important to them, again, you're not going to get the follow through. So I think that as well. And absolutely, you know, we've tried everything for every different type of kid. Again, rather, is it a sticker chart? Is it a prize chart? And I mean, it's all sorts of stuff. The other thing that I would say that definitely over the years is trying to give it the families to do it during times when families are already busy enough. So if they can do it in the car or at the grocery store, or during bath time, during times when they're stuck there, or even, you know what, when the kid is sleeping. And I go back to, again, just even my own little guy, because I had all these ideas and all these plans that I would send home for parents, but until you're really a parent and in it, and a child who has special needs, because I hear my child screaming and crying downstairs right now, and this is my daily life right now. But he'll be sleeping, and that's when I can finally go in and do like cranial sacral therapy on him. And that's the only time I can do it, is wait till he's sleeping, because I can't do it during the day sometimes. But I think, again, finding the times throughout the day that the parents aren't as busy, they have a few minutes of just kind of some downtime. The other thing that we have had really good success with is we've had parents bring in binders, and we create binders with the kids as part of their therapy sessions. So we'll have them separated into, you know, gross motor activities that they're working on, or primitive reflexes that they're working on, fine motor activities. And then the kid, as they bring in their binder, by the time they're done, they have a pretty good sized binder of home programs. Again, these are for the older kids, but even the younger ones. So the families have a visual, and then with that visual, the parents don't have to say, oh, you have to do this exercise today or this week. It's up to the kid. And then we just know that anything that child chooses to have that control, it's going to help them. And we've had really good success with that too.
I like that.
Trying to think of other things.
Yeah. A little success story while you're thinking. Lindsay, I think that was you that made the comment of, you know, when do they have free time? They're busy. One kid that I'm still working with, we're working on fine motor skills, dexterity. He was a preemie. He's about 8 years old now, and just trying to hold a pencil was hard for him. He became so motivated. I got out a special pencil that we had, and it's color changing. I said, and I was just working on some pencil Olympic stuff. You know, you're spinning around, you're scooting back and forth, you're doing this. And we did a couple in session, and he got excited about it. And then I said, well, this cool pencil that we've been playing with, I'm going to send it home with you. And he went, huh? He's like, but I don't want it to go home. I want you to keep it in the car. And I want you to do it when you're driving, and, you know, mom's driving and you're just sitting in the back. That's when you control it. And good heavens, he took off with it. And, you know, he does all sorts of stuff with that pencil now. And it's been fantastic. But it's not a, oh, hey, you know, take this home and lose it and figure out some time when you're busy to do it. It's, you're driving. What else are you doing? Staring out the window. Cool.
Yeah, that reminds me of something, that we did too, Ivan, and that is we created fine motor kits, and we asked them to keep them in the car. So they were only for in the car when they're driving to and from, like, maybe school, or driving for pickups, or to and from, you know, soccer. Just, it has to stay in the car, or it could go to restaurants before COVID. Because again, if they're just sitting there waiting for their food, what's the perfect time? And most families, you know, would go to a restaurant at least once a week. So we figured we could get it in that time. But yeah.
Cool. Another thought that I had was just, the more I've learned about different pediatric settings, it seems like there are a lot of patients, and it is a busy, busy day. So any tips on just how to manage a very, you know, long schedule, or a very hectic schedule, or just a complicated caseload?
Diane will tell you I have a whole lot of Post-it notes all over my computer as to, like, what's priority for me that particular day, week, because I'm in infant toddler visits, and then I go to the school, and then I'm in the clinic. And so having a set schedule for these are the most important things that particular week, I think, is probably my most helpful thing, because I do. Between the two codas and myself, we have a caseload of like 300. So.
I think too, I learned on one of my field works as a student, we had a gal who did like themes for the month or for the week. And I find that if you're doing kind of like this week we're doing gardening and you're just, and of course you're making it just right challenge for each kiddo, but sure makes my charting easier when I go through and I'm like, what did I do this week? Oh, we did gardening all week.
Yeah. Something that I do, two approaches on this one, or two comments on this one. In clinic, I'll write down just little notes, and oftentimes I'll have a theme or set of activities that I'm using throughout the week. But I dedicate specific times to be able to sit down, and when I know it's going to be less crazy, I like to go into the office early in the mornings. I wake up early anyways, and that works for me. And so most people aren't there and it's quiet, and I can put together my documentation and get it done. And then during the day, I often am just run, and then I sit down for lunch, and that's another generally quiet time, and I grab a bite, and then I can get other things done. I pair that with carrier in that, well, Lisa, right, most of us are in the same boat, that we're a therapist and we also have management responsibilities, and so then we have this extra set of balls that we're trying to juggle and keep in the air, and I need to do this, but I need to do this, but what's more important? And then the other side to this, as Brittany, after you had sent out this email, it's just like, man, it's a really good question. And I thought to myself, how often do we forget that we are occupational therapists? And in the sense that we forget our own recommendations for other people of how to manage life. Here we are, we're busy. And then what do we do when we go home? What do we have that helps compensate, that brings that rest and rejuvenation? Do we engage in other occupation, hobbies, routines? What is our occupational profile? When Lisa and I graduated together, and I always remember this assignment. That occupational profile of yourself. You remember that assignment? I hated it. Absolutely hated it, because here I was going to school, and that was my occupation. I went to school, I had a part-time job, I went home, a little bit of time with the kids, and I was out. Like, I had no hobbies, I had nothing else. And so then I was trying to put together this presentation. I was like, I don't know. Mm-hmm. But as I got out, I said to myself, well, this isn't good. I need to be able to have other hobbies. And now I have hobbies in waiting, but to be able to rejuvenate, be able to have something that you're passionate outside of work as well, or find other ways that help replenish and rejuvenate yourself, so that you don't risk that burnout.
I was gonna say, are you in your workshop now?
I'm in my wood shop. Yeah, we're actually right underneath a big wooden and styrofoam cow that I am making because I also do musical theater. So I'm making my computer's under the cow right now.
Sweet.
Yeah. So I would say, Ivan, I agree with you that I actually think about that all the time. Like, I am the worst person as far as an OT, of, again, great at giving advice on how to have that work-life balance. And I'm probably the worst, which is anybody who sees my emails coming through at 2 or 3 in the morning because I haven't gone to bed. I don't sleep a lot. I feel like I'm really bad about doing that. But I work during the day, and when you say you can have lunch, I would do that. It takes me about 3 hours to eat lunch every day, because my door is an open door policy. Mm-hmm. So we have about 20 staff in our clinic. So people come in all day long. If I'm not treating, it's like a rotating door, and it's no joke. People will line up outside the door to come in and talk with me, and I'm like, oh my goodness. So yeah, I'm still trying to figure it out. When I read your question to Brittany, I was like, I wish I knew. It's, yeah. And I feel like, we have a good system as far as, have a practice manager and we have a receptionist and we have a billing specialist. But I still think there's always, again, as an owner of a clinic and the head OT, people always just come to you. And I want that. I don't want them not to come to me. So that's a challenge.
Sometimes you spend the whole day just putting out little fires here and there. I totally get it.
So Kaylee, and I don't know if that's Darcy Carr or not, but like, do you guys, I mean, you guys are now a year in, and even Diane, talking about you survived field work. Do you guys have any thoughts on that, or any like aha moments that you had as a new grad or as, a student out on your fieldwork rotation? Diane, how did you jump into Lindsay's caseload? Obviously, hopefully you eased into Lindsay's caseload.
I'm not gonna lie, it was super intimidating at first because it was like nonstop go, go, go. But what was nice is Lindsay kind of put me in charge of doing like the weekly theme. And so I would spend like my weekend times like getting worksheets, and I'd print off worksheets for all different age groups. So then I always had something to fall back on, like, oh, I have somebody who needs to work on writing. Okay, look, I have like this tracing worksheet, we can do that. Or I have mazes of all different difficulty levels, and I'd always have like a craft of the week. And sometimes there'd be a harder craft, or I'd make a simple craft for like the younger kids. And so having that theme of the week really, really helped me.
That reminds me of something that we've done in our office. This was one of our student projects that we had done. We took and we created a series of binders, and good heavens, we have like 8 of them, and they're different, handwriting worksheets or mazes or puzzles or coloring pages, and all the originals are put in a sheet protector. And then we have a copier right down in our room where we do treatment. And so if we run out of copies and we're just like, oh man, I really need this and I need it right now. And rather than trying to have to research back in, it's like, okay, I'm going to look this up on Google and find something I can use. We can flip through in the kids right there and say, hey, we're going to color a page today. And what should we color? And oh, you like superheroes? And oh, hey, here's Spider-Man. And there's this one or this one. Which one do you want? Okay, hey, let's take it over. And you press the button and there it is. Now let's go color it. And they really enjoy that. And we have the resource, and it cuts down on some of that prep time.
I noticed too with the kids too, they really like going to the copier and pushing the button and putting the paper in. Like they think that's the coolest thing ever. So.
Yeah.
So just an aside too, life-changing. I got this new table in my room, and I put a piece of plexiglass over the top to protect it, and because it had slats in it too, so it wasn't great for handwriting, but put plexiglass. And now we use like dry erase markers on top of this table. My kids love it. Like, and I could slip a paper underneath it, so a maze or a dot to dot or something, I can totally slip underneath and reuse it all the time. So it's been fun.
That's fun.
Okay, so another question, and actually this one I didn't prep you guys with, but it sounds like a fair amount of you anyway dabble in, clinic, infant toddler, school district, and to me, being the not skilled pediatric therapist, and at least 10 years out of school, I don't have the experience of like, what is my mindset in a school system versus in a clinic? But the more I've done fieldwork, site visits, and talked with students and fieldwork educators, I'm learning that there is that, that adaptability of your mindset or your focus points. You guys, am I in the right track here? Does anyone want to talk about that? Like just what is the difference in your approach as a therapist in the school district versus infant toddler versus in the clinic?
I'll go first again. When I was a student in the town that I was in, I heard about, there was kind of this division between schools therapists and clinic therapists, and that they had these different perspectives and they didn't get along. And I was just like, that doesn't seem right to me. And so one of the things that I've done going into schools, and I guess number one, I love having so many different interactions and places that I go. Off and on, we also do home health with adults, and it's fun to do, to shift gears. But in school, there's the demand of the IEP that it be academically related. And then the challenge becomes that the staff sometimes will get an idea in their head of what occupational therapy means in an academic setting, and that's not necessarily true. And so I find it exciting to be able to educate school staff on, hey, this is what occupational therapy is, and we can actually expand what we're doing with these students and the services that we can offer to them. I just picked up a kid that he does fine with visual motor, he does fine with fine motor. He has a hard time with regulation and understanding emotions and the ability to engage in social situations with friends. Well, guess what? What's an area of occupation? It's social engagement. And we are working on those skills within the IEP in occupational therapy. And it's fantastic. And the school is going, wow, yeah, this is exciting. And look at the gains that the kid is making.
I think one thing too is it all boils down to occupation. I've had therapists who go between adults and kids, and I mean, we're all in Idaho, and we kind of have to be jack of all trades sometimes. But if we stay true to what OT is, then I don't think you can fail. Some days will be better than others, but if we all remember this, it's occupation, and we follow our framework, follow our training, and be, we've got to advocate for ourselves that way too. Like Ivan was saying, people don't understand what we do. They see us baking cookies, they see us, making crafts or whatever, and they don't get why we're doing that. So definitely advocating for who we are, in any setting.
I think doing infant toddler, it's so much a coach approach to the parents, with the parents. And so I think it makes it maybe even I'm a little bit better in the clinic perhaps, and maybe even in the school, being able to coach teachers to get some more carryover and follow through, and coach parents in the clinic after sessions to get more carryover and follow through. And so I think actually being in multiple different settings can truly be a benefit, because you get to see different ways of kind of approaching things and kind of combine all of those to get the best approach possible for the kids.
Who in here in Zoom, who here works inside schools? So a couple. And how well do you know the school staff? Have you spent time getting to know the teachers and stop by and say hi? Do you know what their interests are outside of being a teacher? How much have you delved into that relationship to build on, to then have that relationship of trust with who you are as a therapist?
I have a great relationship with all my teachers. I think they know me and know where my skill set lies. And so it's really an easy, very basic approach, like back and forth communication. So it's easy to do that.
Yeah. I'll have teachers just say, hey, he's not on your caseload, and there's just, there's a couple of kids in my classroom. Can you just, how do I get my kids to do this? How do I get my kids to do this or that, or different skills? And it's just fun to be able to give little consults as you're able to, if you're, waiting between this, waiting between that, and just touching base. It's, teachers are busy, we're busy, but
yeah, being
in those moments, I think it,
This I think would really help Bobby, but I think, you know, it's something that you could also use for, I see Johnny over there and Tibby over here.
Mhm. Yeah.
Are you guys in the classrooms mostly, or are you doing pullouts?
Both.
Both.
Yeah.
Cool.
Yeah. It depends on the kid and the situation and
Mhm.
teacher preference, and there's a lot of factors that go in, but
I agree completely. Yep. Teacher preference, kid, what they're working on in the classroom,
Mhm.
all those things.
Cool. So maybe the last question that I have, and I don't know if you guys have a ton on this, but just, I mean, maybe you do, or depends on how deep we want to dive. But as far as like best practice recommendations, or you know, the latest and greatest interventions or evidence-based practice, is there anything, any advice or direction that you would want to steer our audience?
Wow, crickets.
That's a
No,
tough
right?
one. That is a really tough one. I guess I am always looking for the best evidence-based interventions and the best things that are out there. But honestly, I am the type of person where, as an OT, I always tell my students, I tell my staff, you know, we always go to the same things, but at the same time, we need to constantly be thinking outside the box and looking at, this is what I'm seeing. Do I need to go to Lowe's and try and rig something up because I don't know what's out there? I just feel like I am constantly just pulling, not anything. I mean, I don't even know how to explain it, because there are those interventions, but at the same time, what works for one kid doesn't always work for another kid. And sometimes you've tried everything and you're like, this is still not working. And you're just trying to figure out, again, figuring out what motivates them, figuring out what they're driven by, and, you know, going for that. But I always think too, like I research all the time. I am looking on Google all the time, trying to figure out, you know, what is the latest out there on a therapeutic listening program, or a, you know, cognitive brain-based program that incorporates metronome, incorporates, you know, kinesthetics, visual and auditory, or just, I feel like it's never ending and it's great. But at the same time, like, it's never ending. And there's 1,000 things out there that I still want to go out and learn. It's tough because there's a lot out there. So I think there's something for everybody. It's just a matter of finding out, what does your specific child need, and what you as a therapist motivates and drives you. What are you really interested in? And when you find something that you're really interested in, dig deeper into it and get all the training you can, and then move on and you find that next thing that's really going to motivate you, and get all the training you can about, you know, that intervention. So
I think, especially for new therapists, but a reminder for us, a little bit more seasoned therapists. Not that I'm an old therapist, at least I wasn't going to say that. Seasoned a little bit. To remember the excitement in learning. And when I first got out, I would look at continuing ed as, oh, hey, what do I want to learn? How do I want to grow? And more I find myself saying, wow, you know what? Johnny's really struggling with this, and he needs this, and I'm going to find a continuing ed that's going to benefit him. And then I'm going to go after it. I'm going to really learn it. And as I do that, then there's bleed over effect. I'm just like, oh, I can apply this to Sally, and look, this is going to, you know, affect, you know, I always go to Johnny and Sally, George, you know. But it increases my own motivation, and then it increases the ability to affect the child, because I'm now targeting them with evidence-based practice, because I've sought it out specifically to get the continued ed that I need.
I think I kind of struggle with this sometimes too, because I mean, like Carrie said, there are so many things that you could just jump into. I mean, and she just mentioned a few, and in pediatrics, I think you'll find therapists who, you know, maybe they have a specialty in feeding, maybe they have a specialty in anxiety management or whatever, and sometimes knowing that maybe I'm not the best qualified therapist for that client, that it might be better if I give that client to another therapist who has better expertise, or I seek their help in that expertise area. Just knowing, like say your client individually, there's so many things that you can learn, but you know, the kids learning too, the parents are learning too, and being willing to learn is a huge, huge part of that one.
I agree. Being able to brainstorm and know which therapist, okay, I'm really struggling with this, and I know that this is probably the issue. I know that this therapist in our office has got a whole lot more training in this than I do. So I need to go pick her brain and figure out where I'm missing or what I'm not quite getting. And so, you know, being able to have people to bounce ideas off of is huge. Even as seasoned therapists.
Yeah, I guess that's kind of like a little segue because we just talk as a program, you know, about like seek out formal mentorship, or, you know, is that rural position where you're by yourself, is that a great place to start your career? Which, I mean, it can be, but, you know, just that mentorship and camaraderie and bouncing ideas off of one another and learning from one another is so huge in any setting. Do you guys have formal mentorship programs, or it all just kind of naturally happens in your clinics?
We've tried setting up formal mentorship before, but the way that our clinic runs, for example, Monday today I was over in our Burley clinic, and tomorrow I'm going to be in Twin. Wednesday I'm going to be at home visits and then out to the school for the deaf and blind, and then Thursday I'm out at Hanson School District and then back into the clinic, and then Thursday morning I'm in the clinic in Twin, but then I'm in our Jerome office. You know, and if I'm attached to one other therapist as their mentor, they see me twice a week. And what we found is that we've opened it up and so that it's much more informal, but it works very well for us. And then our department heads have monthly check-in meetings with each therapist, and they just bring them in during, we have Friday staff meetings and we feed them lunch. We just carve out that time specifically for it. And but the second Friday of each month, rather than having a group meeting, it's just, hey, this is when you'd normally be in a meeting, and now we're just going to have, you know, 5-minute check-ins, longer if you need it. And so then, you know, beyond the mentoring that they get through each other and the other therapists, we have a staff of about 40 now, and it's just so yeah, it's incredible. But then they get that check-in with the department heads.
Yeah, we don't have a formal mentorship either for kind of the same reasons. I'm not all over the place, but I am all over the place when I'm at the clinic. Again, rather it be billing coming in, or the practice manager, or the receptionist for scheduling, or if I have a student, or, I mean, it's just, I feel like when, again, you're kind of treating versus also trying to run a business, it's really challenging to have a formal mentorship program. What we do though is we have our therapists kind of into different teams. So we have an OT with maybe 1 or 2 codas underneath, or it might be 2 OTs with 2 codas on a team. They meet once a month. But then we also do, you know, again, it's not a formal mentorship, but it is always, we are really, really big into continuing education. I really, really strongly encourage everybody to do that. And people are just really open to, hey, I watched this course, this is what I learned. Even if it's not in a formal way, just people are always sharing what they're learning. And I am one that, as I'm walking through the clinic, will just jump into everybody's session. I apologize a lot, like, oh, I didn't mean to take over your session, but I just do. But I think that's kind of our informal mentorships too. Like, hey, I see you're having a hard time. Have you tried this? What about this approach? Have you ever tried this? And I think a lot of our therapists are like that. And the team itself is, everybody just kind of helps out. We're all, you know, in a big gym. We have our individual treatment rooms, but really we all treat together.
Yeah, that's cool.
We
That
don't
was one thing I
necessarily
got to see at the clinic with Lindsay though too, is she has 2 codas underneath her, and just to see those other two codas come in and they can just pick her brain at any moment in time. And if, like, we were at the school one time and Darcy was having a really hard time with one of those kids, and it was really cool to see Lindsay just jump right in and help her like right away, because you could just see that look of panic on Darcy's face, like, I don't know what to do. But so I think just having that relationship built between like the OT and the coda is huge.
Yeah, and we don't have like a set mentorship program per se. I mean, we kind of have this particular therapist is really great in this area. So if I know I'm struggling in this area, this is who I go to. And this particular therapist is really great in this area. So I know if I'm struggling with this, like this is who I go to. And so we've kind of believe we have a lot of therapists who are really good in like particular areas. I mean, they're very well rounded, but particular areas. And so because we have so many therapists and so many in different areas, I think it's so good because we know, like, I can go to this therapist in this area because this is where I'm struggling, and this therapist is probably going to have this answer for me. So having that.
Yeah, that makes perfect sense. Well, cool. I guess I'm going to open it up to any questions that anyone, newer therapists, seasoned therapists, old therapists, any questions that anyone else has? Now that I've asked all of my questions. Well, cool. Well, we made it to an hour, so I can respect everyone's time. And just once again, a huge thank you to our guest speakers. We appreciate your knowledge and your willingness to take time out of your hectic days to join us and kind of talk about this very cool topic.
And Carrie
you,
and
Brittany.
Ivan, we are really trying to get this out there. We're going to start up again in the fall. We blast it out on Facebook, as much as we can, but we're getting not a great, response of people that are not the speakers. So if you can help us promote this, I think it's so valuable to have the opportunity to just, be camaraderie with your OT practitioners in the state of Idaho. With Zoom, we can reach the state and beyond.
I agree, Joanne. Yes, and that is, we're in the same boat with IOTA. I mean, we say the same thing, like we hold little events and the only people that show are, the board members, but that's okay. Like, we just figure we're still a lot further along than what we were back in 2015. And, again, we just keep promoting. And I think the more of us that get together and show that we are passionate, everybody's here to work together for our patients and throughout the state. And again, Zoom is such it's an amazing opportunity for us to all be together throughout our state. So I hope more people join in over the years. So.
And I mean, we are recording, so I have kind of peeked at how many views we're getting. I think there is interest because I know it's a challenging, time of evening and kids and activities and whatnot. So that is a nice thing of people are watching the recording. So even though majority of our attendance tonight was forced voluntold speakers, no, I'm just kidding. People will watch this, and I think we are touching more than we really realize right now, and then it will build off of it. So yeah, so we're looking forward to that. And I'll do, well, since I'm still recording, my final plug for I'm always open to topic ideas, because obviously I want to pick topics that are relevant to people, something somebody wants to learn more about or hear about, or maybe there is, like Carrie and your craniosacral therapy, like I don't know much about that, so I mean, these topics that we can touch a lot of people or educate or pass on specialties or knowledge that we have acquired somewhere along the way. So I'm open for any ideas or topics or people that want to share something that they know. So thank you guys all so much, and we will see you after the summer. So have a great summer.